for giving me the opportunity to speak about facial nerve palsy treatment and rehabilitation. Jumping into the topic, so this is a clinical condition characterized by loss of motor function affecting the muscles of facial expressions. There are varied etiologies classified based on the anatomical level of functional disruption and by the nature of responsible pathological processes. There are three degrees of nerve injury, one being neuropraxia, axonotmesis, the third one being neuronotmesis or the grade 5 nerve injury. The facial nerve is completely divided here, or it is sacrificed during surgery or severed as a result of trauma. In neurotmesis, the recovery cannot occur without surgical nerve repair procedures, as the epineurium needs to be intact for axonal regeneration down the repaired neural tube. After the repair, the length of time to recovery depends not only upon the distance of the axons that have to regenerate to reach the target tissues, but also that the patency of the neural tubes is maintained. Coming to the facial nerve, it is divided into extratemporal, intratemporal, and intracranial segments. Lesions along the course of the facial nerve can disrupt the efferent motor impulses, resulting in facial weakness. There are intrinsic tumors of the facial nerves like schwannoma, hemangioma, or paraganglioma. In these cases, treatment can either be conservative or interventional. Interventions like decompression, resection of the lesion with an interposition graft or stereotactic radiosurgery. The extrinsic lesions affect the intracranial facial nerve are like vestibular schwannoma, meningioma, epidermoid, or METs. Extrinsic lesions affecting the intratemporal facial nerve like cholesteatoma, tympanic paraganglioma, uh, or bony diseases like osteoma, fibrous dysplasia, and Paget's disease. There are extrinsic lesions which affect the extratemporal facial nerve as well. Uh, the primary pathologies of the parotid gland make up the majority of these etiologies, and they can result in facial palsy in these segments. In general, any neoplastic lesion of the parotid gland that causes facial palsy is malignant unless proven otherwise. Coming to the diagnosis, the primary modality of imaging is gadolinium enhanced MRI, encompassing the entire course of the facial nerve from the brainstem to the parotid. There are other modalities such as CT scan, which is seen particularly useful adjunct for lesions involving the intratemporal facial nerve, uh, or uh, other forms of PET scan, which can differentiate paragangliomas from other tumors. Tissue biopsy is rarely indicated except when malignancy is suspected. How do we assess? The objective assessment of facial palsy and its response to treatment is complex. There are multiple grading instruments like the House, Brackman, and Sunnybrook facial grading system. Those widely used are limited by inherent subjectivity intrinsic to any clinician reported measurement tool. The truly objective outcome measurements in facial palsy, they generally rely on quantitative assessment of facial motion using computerized video software. Although the assessment of composite facial movement or motion will play an essential role in the objective measurement, it should be emphasized that the patient's perspective on their day-to-day function should remain an essential consideration. Although not truly objective, the patient reported outcome measures provide very critical information on a patient's psychosocial well being, As such, they should form a central part of any patient centered outcome measurement set for those with facial palsy. Uh, Widely used PROMs in facial palsy include the FDI and the face scales. Currently, a single comprehensive objective outcome measurement tool to evaluate patients with facial palsy doesn't exist. Given the breadth of physical, psychological, and social sequelae associated with facial paralysis, it is likely that the combination of objective clinical and patient reported measurement tools will form part of the routine analysis of patients at both their first presentation and the ongoing follow up treatment. Coming to the surgical techniques, just brushing up some basics. When the axons are injured or disrupted, they undergo Wallerian degeneration, a process wherein the nerve fibers degenerate within a 10-day period, with relative preservation of the outer myelin sheath. The contents of the nerves then come out as axonal sprouts to form a growth cone, which is guided along the myelin tracks left behind. Uh, this is powered proximally by a host of growth factors, which is called neurotropism, and attracted to the distal content by chemotactic factors, which is called neurotropism. Why this process works for distance of up to about 1 centimeter, the axonal growth sprouting does not work well as for larger gaps, and in these situations, it calls for a nerve graft to serve as a guide or a conduit due to the rich content of myelin and neurotropic factors, allowing the proximal growth cone to reach the distal nerve end in time to innervate the motor nerve end plate. With regards to the motor end plate, they degenerate beyond 12 to 18 months, depending on the age and comorbidities of the patient. Hence, it is essential that the process of regeneration occurs within this time frame. The other confounding factors in nerve healing is that even if the physical process of the nerve conduction is re-established after any injury or repair, if the cortical processing of stimuli from a particular nerve subset is inhibited or altered in the interim, the subjective sensation of feel will be different and be interpreted by the patient as either paresthesias or dysesthesias. Hence, the process of returning the nerve function to its optimal premorbid level is dependent on the local process of axonal regeneration, the functional preservation of the motor end plate or the sensory nerve endings, as well as the cortical rehabilitation in the interim. The end plates degenerate between 18 to 24 months after the onset of the complete facial nerve injury, although recovery is possible in up to 26 months post injury. If there is no evidence of muscle electrical activity on an EMG, this is a contraindication for late nerve repair. In cases where there is no gap or tension during nerve coagulation, direct approximation of both proximal and the distal nerve ends yields the best results, as there is only one repair site for the axons to traverse. The key here is to get as many axons across the gap and, more importantly, into the right distal fascicle. To achieve this, correct nerve alignment during repair is very vital. The alignment techniques include matching the vasa nervosum, the perineural repair, and identifying the motor and sensory fascicles within uh, the ACE enzyme for more accurate coordination with neural sutures. While nerve alignment is easier with perineural sutures, additional sutures within these nerve cables come at a cost of increased scarring, hence high propensity for axonal misguidance. So there is one school of thought which uses minimal epinural sutures, maybe just one or two to orient the coaptation and fill the gap with synthetic gel to allow the axons to traverse through this short space and reach the right distal fascicle. This comes after work of Lundberg on the peripheral nerve regeneration in rats, uh, where he was able to bridge about 3 to 5 mm of gaps with a celastic tube filled with normal saline, and this allowed axonal regeneration. Post-operatively, these rats showed excellent return of motor function, and the biopsies from these sites revealed normal neural architecture, which corroborated nerve healing. This was also used in clinical cases with success. So the concept here is that the axons are sufficiently close to the target fascicle to grow into them without the handicap of scarring or excess sutures. But to date, the ideal balance between alignment and minimizing scarring has yet to be determined. When dealing with nerve gaps or attempted primary coaptation under excessive tension, nerve grafts are the best solution as they allow for minimal tension coaptation. Uh, the techniques involve again epineural, perineural, or minimal suturing with common nerves, graft sites being sural nerves, medial and lateral antebrachial, greater auricular, the lateral femoral cutaneous nerves, and as the saphenous nerves. Uh, it is to be noted that most of these donor nerves are sensory in origin. It is possible to harvest motor nerves like the anterior interosseous nerve, specifically for mixed nerves. There is also an argument using mixed or motor nerve grafts over sensory nerves when repairing mixed nerve defects, as there are significantly better outcomes with them. But the drawback is the morbidity, as you are sacrificing mixed or motor nerve. Alternatively, non-neural interposition tissues like muscle and vein grafts have also been described, but not for nerve defects which are greater than 3. There are instances where either or both the proximal and the distal facial nerve stump are absent, in which case an alternative nerve, usually another cranial nerve with sufficient axoplasmic flow and nerve physiology, is chosen to reinnervate the facial muscles. The usual donor sites are masseter or hypoglossal and spinal accessory nerves. The other technique is cross-facial nerve grafting, which involves coaptation of the nerve graft to a suitable facial nerve branch on the non-paralyzed side of the face and then passing it across to the affected side. The nerve graft is then connected to the facial nerve or a branch of the or to the nerve branch on the paralyzed side. The sural nerve is commonly used. Uh, this is performed if performed early, can produce a symmetrical and spontaneous facial movement, but the results in isolation are very disappointing, and it's more often performed in combination with free muscle transfer or dual innervation techniques. It is more effective in partial injuries to enhance the residual function. With regard to nerve transfers, use of hypoglossal nerve as donor nerve can cause a significant masticatory and speech problems. In response to this, partial nerve transfers can be used. Example, the babysitter procedure, wherein part of the hypoglossal nerve is used to preserve the motor entrails of the targeted facial muscles until a good alternative reinnervation, uh, for instance, from the functional cross facial nerve occurs. Uh, Many have gone a step further to introduce the epineural window concept, where a flap of the epineurium is raised and an end-to-side coaptation is performed, achieving similar results. Currently, the Masseteric nerve, which is a branch from the mandibular division of the trigeminal, is gaining increasing popularity as a donor nerve. This likely relates to its proximity to the terminal buccal and the zygomatic facial nerve branches, and there's minimal donor site morbidity. Also, because of its high axon count, the, the body of evidence showing co-contraction of the masseter muscle when smiling in almost 90% of the people. The only disadvantage of this is that it has a very low resting tone, in contrast to that seen in functioning facial nerve. Uh, Pedicle nerve fascicle turnover flaps have been introduced by Oshima by using supermicrosurgery techniques uh, on nerves and vessels which are less than zero point 0.8 millimeters. So where there is retrograde dissection of the distal nerve fascicles, especially from the buccal branch of the facial nerve. So a minimum base of 5 millimeter before pivoting it on the distal stump and coapting the distal nerve fascicle to the proximal facial nerve stump. This has been used for facial nerve defects to good effect in selected cases, but this requires careful patient selection and planning. Also, free tissue transfers have been used um, quite regularly along with vascularized nerve grafts. The The neurotized free flaps are used in situations when both the skin cover, the bulk, and the dynamic reanimation are required following extensive loss of facial tissues. Whereas vascularized nerve grafts are primarily used for irradiated or poorly vascularized tissues, as they have been shown to exhibit a superior axonal regeneration and decreased fibrosis. Uh, some groups even suggest that the VNGs should be the baseline standard for peripheral nerve grafting procedures, as their greater vascularity contributes to a better nerve regeneration and improved outcomes. The current coming to rehabilitation, the current trend is to optimize cortical plasticity postoperatively in conjunction with occupational and physiotherapy, uh, where they're exposed to specific exercises like mirror visualization feedback or feedback error training, which help in cortical function within the neurosome. Uh, Factors which predict the outcome of cortical plasticity training include attention, stimuli patterns, temporal delivery of exercise, either spatial or en masse pharmacological intervention with neuroprotective drugs, the duration of training. Duration of training is specifically important as it consolidates the neural gains achieved through synaptogenesis. In terms of preservation, the function of the motor end plate post injury, we do not have a solution yet. There are no pharmacological interventions to preserve this motor end plate through, although NAC has been designated as neuroprotective drugs and has been used in diabetic neuropathy in early stages. Uh, so, as far as if we look at animal studies, only mechanical stimulation of muscles has shown some promise in preserving the motor end plate. Uh, so all peripheral nerve injuries must be viewed as injuries to the nervous system, starting from the cortical orientation of the brain, re-establishment of the nerve conduit, and finally stimulation of the motor end plate. So any trauma to any one of these components affects the other by the same token, and any effort to heal these needs a coordinated surgical response to the peripheral nerve using these techniques, which allow for reinnervation of the motor end plate within 12 to 18-month period. Because beyond this, reinnervation is pointless. All this has to happen while the cortical plasticity is preserved. Medical treatments also have a role to play, especially in cases of synkinesis. All these happen post surgical intervention. Uh, Botulinum toxin A is a neuromuscular blocking agent that results in that causes paralysis of the muscles adjacent to the injection site. This arises through the coming to electrical stimulation. The clinical experience suggests that patients who use electrical stimulation develop greater level of synkinesis, which hinders their ability to regain quality motor function and expression. This is as a result of excessive excitation of the newly innervated muscles. Patients actually have to be advised massaging their face twice daily, which provide mechanical and sensory stimulation, which helps maintain the circulation, mobility, and awareness of the facial muscles. It also maintains that feeling of movement, which cannot be gained via the electrical stimulation. The main focus of early weeks of recovery is to protect the eye and the facial massage. Um, there are two problems which require different strategies to manage. The facial asymmetry can occur as a result of abnormal synkinetic movements on the side that is recovering from facial paralysis. It can also occur when the side that has not been affected by facial paralysis becomes too strong and pulls the weaker side of the face across. So, so here the nerve impulses in post facial paralysis, there is a lot of synkinesis which happens. So the impulses are poorly coordinated and they fire at the wrong term and the wrong sequence. So by identifying these individual nerves which supply the facial muscles, surgeons are able to remove part of the nerve to the muscle that is either too powerful or provide or those that provide synkinetic twitches with the aim to improve the tone and symmetry. So this is selective neurectomy, which is generally performed under GA, where we use a facelift incision, identify specific nerves, tag them, and then bring them out through another small incision, and then in a second stage, either severe them along with patient feedback. Uh, there is also a procedure called myectomy where specific muscles which are causing these synkinesis can be synkinesis can be severed. So coming to the conclusion, the evidence base guiding the management of facial palsy continues to grow. The importance of patient-reported outcome measures and their association with clinician-reported outcomes continues to be better understood. With this, PROMs are now considered very essential in evaluating patients with facial palsy, and they help to ensure the treatment is patient-centric and focuses on the patient's psychosocial well-being. Uh, so the use of PROMs to generate an evidence base in support of the myriad of invasive and non-invasive interventions available will help ensure that the treatment offers true value to the patients. So both psychology and physical therapy are essential non-invasive treatments which have to be available within a comprehensive facial palsy MDT. There's also increased appreciation of psychosocial well-being here, uh, where there has been a clear establishment between facial palsy and anxiety and depression. Uh, so we need uh, to meet these research objectives. There has to be a good collaboration among centers with facial palsy. Uh, at the highest level, where robust high-level research is conducted with adequate patient numbers. Thank you.
Little evidence for increasing practice of giving different sources of power for different parts of different branches of the facial nerve. Get the masseteric nerve and give it to the nerve. Then take cable grafts from the main trunk and give it to the orbicularis oculi, and oris will be something else. So, does anyone have this kind of experience using different power sources to the nerve? The whole idea is that there should not be synkinesis, and it's very easy to have synkinesis with a nerve which has so many different branches coordinating such group of muscles. So, one group of muscles gets one power source. So, any experience with that?
So, I think there is enough evidence today that you should provide different sources. So if you're done a parotidiectomy and you have had to sacrifice a nerve at the stylomastoid foramen, so now you would have two main trunks. One was the zygomatico-temporal, and you would have the cervicomandibular. So then you would want to connect the cervicomandibular to an unsubbed hypoglossal, and it is no longer necessary to divide jump graft it onto the hypoglossal. So you can use the answer hypoglossal to connect to the lower, because that also has a similar nerve dimension. And the upper trunk can be connected to the masseter. Today we have a ability to identify the nerve to the masseter very easily. So usually there are 2 or 3 branches, so even the masseter doesn't get denervated completely. So one branch of that masseter can be connected to the zygomatico-temporal. Very early results, but we have had 2 patients who have had good recovery at the zygomatico-temporal, but not much in the mandibular.
Masseteric has very good tone otherwise, so the recovery will be much quicker. The only thing is, the patient will have to be retaught everything.
Because of the plasticity of the brain, over time the patient will be able to recover the and have a separate function for the upper trunk and the lower trunk. But marginal, we have not had good response.
I have involved in 2-3 cases along with the plastic surgeon. Patient had a total facial nerve paralysis, 6 months, 2.5-3 years. So one case is 6 months. He did both the masseteric anastomosis as well as the facial graft, tensor lateral fascia graft,
Dynamics, statics.
Yes, sir. Yeah. But the result was quite satisfactory in those 2 cases. But searching and getting the masseteric nerve is bit difficult unless if you do a total parotidiectomy, a parotid exposure, getting the masseteric nerve is not so easy. In fact, it was the first exposure. I struggled to get the masseteric nerve because we have to go deep to the inferior to the zygomatic and separating the muscle fibers. Getting the facial masseteric nerve is not so easy.
You can get it. Just that, as you said, you should have done the entire total parotidiectomy and have access to the posterior border of the ascending lungs. So that is how you can go there.
Okay.